It's time for another warm-up review. Let's get going. Which protein is involved in transporting an endocytosed vesicle from the plasma membrane to the endosome? So you can see the clathrin coat endocytosing the vesicle and then uncoating here. So it is clathrin. Next, which developmental structure matches each of the following descriptions? So first we have the fetal placenta structure that secretes HCG. That's going to be the syncytiotropoblast. And then the maternal component of the placenta, that's going to be the decidua basalis. Next question, what is the main inhibitory neurotransmitter of the CNS? In which diseases are levels altered? So what's the main inhibitory neurotransmitter? That's going to be GABA. And then in which disease are the levels altered? You have decreased GABA in things like anxiety, also in Huntington disease. So with Huntington chorea, you have decreased GABA and decreased acetylcholine as well. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to talk about headaches, which are a 4 or 5-star topic for step 1. There are a lot of different kinds of headaches and lots of different causes of headaches. You need to be able to recognize some specific headache syndromes. There are 3 main headache types I want you to focus on. You've got tension headaches, migraine headaches, and cluster headaches. Let's walk through each of these one at a time, starting with tension headaches. Tension headaches cause constant, non-throbbing pain that lasts for about 4 to 6 hours on average, but possibly several days. They occur in the frontal or occipital regions, most commonly bilaterally, kind of in a squeezing nature, or they might feel like a tight band on the head. Tension headaches are not associated with sensitivity to light or loud noise. They are not associated with vision disturbances, nausea and vomiting, or any focal neurological changes. If you have any of those findings, you should be thinking about another cause of a headache. So that's tension headaches. Think about muscle tension causing that pain. Let's talk about migraines next. Lots of severe headaches get called migraines, possibly inaccurately, but you need to be able to recognize the features of a true migraine. One of the classic features of a migraine is an aura. Now, not all migraines are preceded by an aura. In fact, most migraines aren't preceded by an aura. So we classify migraines as either a migraine with aura or a migraine without aura. The aura might include visual changes, such as streaks of light in the periphery of your visual fields. That's called a scintillating scotoma. Or sometimes a migraine aura might be an unusual smell just prior to the headache. That can be similar to a seizure aura. In your study guide, there are a list of diagnostic criteria for migraines, and you'll notice that an aura is not one of those criteria. Again, only about 25% of patients who have migraines will have an aura before the onset of the headache, but these individuals do have a higher incidence of stroke. So let's look at the diagnostic criteria of migraines. The headache typically lasts 4 to 72 hours. It's a unilateral headache. It's got a throbbing, pulsating quality to it. Some migraines are worse than others, but migraines are generally severe enough to prohibit daily activities. Tension headaches don't normally prohibit daily activities. Migraines will. Migraines can be aggravated by routine physical activity. And with a migraine, you should have at least one of the following: nausea and vomiting, or photophobia or phonophobia, sensitivity to lights or sensitivity to loud noise. These patients just want to lie in a dark, quiet room until the migraine passes. Migraines are 2 to 3 times more common in women than in men. Tension headaches are just slightly more common in women. So if they give you a male patient with a headache, less likely to be a migraine. And then our third major cause of headaches is a cluster headache. Cluster headaches are much more common in men than in women, about 4 times more common, especially in youngish men, like 20s and 30s, and especially in young men who smoke. A cluster headache is strictly unilateral. It causes severe pain, often described as piercing or a boring pain, like someone's boring into the patient's head with a drill or something. And it's often located near one eye, so this is kind of like a periorbital pain or can be retroorbit behind the eye. Cluster headaches don't throb or pulsate like a migraine. It's a constant pain. And again, no aura here either. The headaches last for anywhere from 30 minutes to 3 hours. They can often occur daily, at the same time, every day for 4 to 8 weeks. It's a predictable pattern. and then eventually the headaches stop for several months and then return 1 or 2 hours the same time every morning for another month. So these headaches tend to be clustered together in a time. That's why we call them cluster headaches. Cluster headaches might be associated with a partial Horner syndrome, consisting of ptosis and meiosis, but not the anhidrosis, which is why it's a partial Horner syndrome. The patient may also have eye redness or tearing or rhinorrhea or nasal congestion, all on the same side as that terrible headache. Now let's talk through some of the treatments for each of these. Tension headaches are generally treated with NSAIDs like ibuprofen or naproxen or acetaminophen. Migraines are commonly treated with triptans such as sumatriptan, rizatriptan, or zolmitriptan. Let's talk about triptans for just a moment here. These triptans are all serotonin agonists, which cause some vasoconstriction. They also modulate neurotransmission in the trigeminal nerve. So the triptan drugs can be used for migraines or cluster headaches, or any severe headache. But classically, we use them for acute migraine. The sooner you take a triptan at the onset of a migraine, the better it will work. If you wait until the migraine's been going on for hours and hours, the triptans aren't going to work as well. So migraine patients should be instructed to take the triptan as soon as the headache starts, or as soon as they begin to experience that aura, or some migraine patients will have a prodrome, where the headache hasn't really begun, but they can feel it coming on. So take the triptan as soon as possible for the best effect. Triptans also have some important side effects. Because they cause vasoconstriction, they can vasoconstrict the coronary arteries. Therefore, triptans are contraindicated in patients with coronary artery disease and also patients with prinzmetal angina, which is due to coronary artery vasospasm. Triptans are also relatively contraindicated in pregnancy because we don't want to constrict the vessels to the placenta. And then for treating cluster headaches, you could use a triptan, and you could use NSAIDs or acetaminophen, but the main treatment I want you to remember is to give 100% oxygen through a non-rebreather face mask. This will abort the headache in as little as 5 minutes, although you need to keep giving the mask for at least 15 minutes so the headache doesn't recur. For your test, 100% oxygen is the treatment of choice for cluster headaches. So far, we've covered the 3 big primary headache syndromes: tension headaches, migraine headaches, and cluster headaches. But there are lots of other things that can cause headaches, like meningitis and giant cell arteritis, brain hemorrhages. We're not going to cover every possible headache in detail right now. We'll cover those in other videos. But I do want to quiz you a little bit so that you can compare the diagnostic features of different kinds of headaches presentations. There's a big table in your study guide, and that says, what's the most likely cause of headaches based on each of the following descriptions? Some of the headaches are syndromes we've just been talking about, and some are those that we're going to talk about later in the course. So pause the video and try to answer these, and then I'll go through the answers with you right after you attempt it on your own. Ready? Let's go through these answers. What's made worse by foods containing tyramine? This is a migraine. Patients with migraines should try to avoid tyramine-rich foods. So where do you find tyramine? That's in aged foods, as aged foods tend to have more tyramine, which can trigger migraines. So think about brown bananas, aged cheeses, aged meats and wines, things like that. The other one is an obese female with papilledema. This is a classic presentation of idiopathic intracranial hypertension, aka pseudotumor cerebri. Or it could be a case of hydrocephalus. Anytime you see papilledema, you need to think about increased intracranial pressure. But in that obese female, that might be a clue that this is idiopathic intracranial hypertension. What about jaw muscle pain when chewing? That's jaw claudication, and that can suggest giant cell arteritis, aka temporal arteritis. This is a form of vasculitis, so we're going to cover it more in the cardiovascular section. What about periorbital pain with ptosis and meiosis? It's a cluster headache. Photophobia and or phonophobia is more typical of a migraine. Bilateral frontal or occipital pressure, that's tension headache. What about a patient with headaches who's using topical retinoic acid for acne? Retinoic acid is vitamin A, and remember, vitamin A toxicity can cause idiopathic intracranial hypertension. lacrimation and/or rhinorrhea associated with headache. That's cluster headache. What about a headache with an elevated SED rate? Giant cell arteritis again. What about a patient who says they're having the worst headache of my life? And that's definitely a buzzword for subarachnoid hemorrhage. Headache plus extraocular muscle palsy. Think about cavernous sinus thrombosis. Scintillating scotoma prior to the headache. That's a migraine with aura. Response to 100% oxygen supplementation. That's cluster headache. Trauma to the head, followed by a headache days after the event that persists for a week and doesn't go away. That would be classic for a subdural hematoma. Severe headache plus fever or neck stiffness. Definitely think about meningitis. What about constant headache for weeks with neurodeficits and/or seizures? That's pretty worrisome for a brain tumor. Brain tumors typically cause a constant headache that doesn't come and go. It's just there all the time. It never gets better. It just gets worse and worse and worse as the week goes on. We have an entire video dedicated to brain tumors later. Now it's time for the end of session quiz. So work on those questions and we'll go through the answers together. First question. What features allow you to distinguish a migraine headache from a cluster headache or a tension headache? With migraines, you may have an aura or a unilateral throbbing pain. You also have nausea, vomiting, photophobia, and phonophobia. And the time frame is about 4 to 72 hours. With a cluster headache, you have daily headaches in those clusters of time. It's unilateral, but non-throbbing, and it's usually localized around one eye. You might have tearing or rhinorrhea with it. And a cluster headache is a shorter time frame, usually 15 minutes to 3 hours. And then a tension headache doesn't have any of those things. You'll just have a bilateral, frontal, or occipital pain that's typically not too severe, and it can go on anywhere from a few hours up to a week. What's the mechanism of action for sumatriptan? It's a serotonin agonist, specifically agonist of serotonin 1B and 1D receptors. Next question. What are the contraindications to sumatriptan use? We don't use triptans in patients with coronary artery disease or prinzmetal angina because they cause vasoconstriction and they're also relatively contraindicated in pregnancy. All right, that's all for now. We'll see you next time.
Do you suffer from migraine headaches? Did you know that many common foods can trigger migraines? Patients who are prone to migraines should avoid alcohol, chocolate, caffeine, aged cheeses such as cheddar, Parmesan, and Swiss, foods rich in tyramine, including processed meats, pickles, onions, olives, certain types of beans, raisins, nuts, avocados, canned soups, and red wine, monosodium glutamate, aspartame, nitrates and nitrites.
Stop! Are you trying to kill me?
Sorry, I guess I got carried away.